So hi everyone, welcome to our RATS Learning Lab. Today I'd like to welcome Amanda Letheren from the University of Tennessee, Knoxville. Today Amanda will be discussing a new study that's recently received IRB approval, looking at treatment adherence for CRC patients, specifically in the Appalachian population. We will have time for questions at the end, and with that I will hand it over to you, Amanda. Thank you for joining us.
Thank you, Reese. I guess I'll go ahead and share my screen and pull up my presentation.
Great.
All right. Okay, so good afternoon. Thank you for having me here today. I'm really excited to share my research with you all. As Reese was saying, my name is Amanda Letheren, and I'm a second-year doctoral student in the Department of Public Health at the University of Tennessee. And I work with my advisor, Dr. Jennifer Japson, and I've worked with Dr. Eric Heidel, who is a biostatistician at the University of Tennessee Medical Center. So before I jump into this project, I wanted to give you a little background on my research. Broadly, I've focused on rural health and cancer disparities. So my main focus has been with cancer control and prevention in rural areas. And I've been really fortunate enough to work with my advisor on this project dealing with colorectal cancer survivors in Appalachia and their adherence to treatment. So the agenda for today, I'm going to go into the background of colorectal cancer and disparities we see in Appalachia, and then I'll move into my research objectives, which feeds into my first project on this topic. And this one has been completed, so I'll go over the methods and results from that one. And then I'll move on to the second project on this topic, which is currently in progress and I have IRB approval with. And I'll go over the methods for that section and then its current status. And then I'll wrap it up with a few lessons I've learned so far and then future directions with this study. So as you probably know, colorectal cancer is the second leading cause of cancer mortality among adults in the United States. In Tennessee, it's even worse. Tennessee bears an even higher burden of CRC mortality, coming in at 17.6 per 100,000, which is higher than the national average at 15.5. Furthermore, the Appalachian region of East Tennessee experiences an even greater burden of CRC mortality rates. Whoops. Continuing on. So we thought patient adherence to the recommended treatment guidelines may be one factor that contributes to this heightened burden of CRC in this area. So why is adhering to the recommended treatment guidelines important? Well, because it helps reduce risk for future cancer recurrence, metastasis, and then also decreases CRC mortality. And this may influence the CRC disparities we see in this particular region. The World Health Organization defines adherence as the extent to which a person's behavior, so for example, taking medicine such as cancer treatment, corresponds with agreed recommendations from a healthcare provider. So we have this notion or assumption that all patients adhere to their treatment guidelines as provided by their physician, but we're seeing in the evidence that not everyone completes treatment according to the recommended guidelines. So for example, in a study on breast cancer, only 49% of patients diagnosed with stages 1 to 3 breast cancer fully adhered with the recommended treatment therapy. So we're learning that not everyone actually adheres to the recommended treatment. So patient adherence may contribute to these higher colorectal cancer mortality rates. There's little evidence concerning adherence to treatment in Appalachia. The literature is very limited, but I did find one article that looked at the determinants of adherence with the recommended CRC treatment, specifically for residents in Appalachia. In this article, they found that lymph node assessment, chemotherapy, and radiation were associated with age, stage of cancer, and race. But these findings aren't entirely generalizable. They're limited to patients who are over 66. They didn't look at colorectal cancer surgery, which is one of the recommendations for treatment, and then other demographics are still unknown. So there's still gaps in the literature on this topic. For example, rates of adherence to CRC surgery remain unknown, and then the associations between demographic and clinical characteristics, and then adherence to treatment, surgery, chemotherapy, and radiation are still unknown. So our research objectives for this study were twofold. The first one is to describe adherence rates for recommended CRC treatment, including surgery, radiation, and chemotherapy among CRC patients in Appalachia. And then the second research objective is to explore factors that may be associated with adherence to these three different treatments among CRC patients in Appalachia. So to tackle these objectives, we did a mixed method study. So for the first project, we had a retrospective study designed to determine rates of adherence to treatment. And this one has been finished, and I'll get into that one in just a second. And then the second project is taking qualitative interviews to explore factors that may be associated with adherence to treatment, and that's the one that's currently in progress. Okay, so for project number one, this is the retrospective study design. We use quantitative data from the American College of Surgeons National Cancer Database, and it's used to describe Appalachian CRC patients' adherence to recommended treatment. Cases were diagnosed between 2000 and 2015. We had about 700,000 colorectal cancer patients. About 200,000 are Appalachian, and then about 500,000 are non-Appalachian. And our outcome variable was treatment, so either surgery, radiation, and chemotherapy. And then the independent variables that we looked at that are from the database are days from diagnosis to treatment, age, gender, and race. We also looked at a few covariates, including insurance, income, education, and treatment facility. So for the results, we had a positive finding compared to non-Appalachia colorectal cancer patients. Appalachian patients were more likely to adhere with recommended treatment, which this is great news. So about 59% had greater odds for adhering to surgery, 35% greater odds for adhering to radiation, and then 26% were more likely to adhere to chemotherapy, and these were all significant. However, still 1/3 of these patients are still not adhering to the recommended treatment, which you can see in the pie chart on the right. So this is a table of our multiple variable analyses for treatment adherence among Appalachian colorectal cancer patients specifically, so non-Appalachian aren't included here. So I'll go over some of the significant findings that we found. For age, patients 70 and over were less likely to adhere with radiation and chemotherapy, and this was significant. For males were 25% less likely to adhere with radiation, and then 11% less likely to adhere with chemotherapy. And then moving down the table, race and ethnicity, African Americans were less likely to adhere with surgery by 57%. And then for days to treatment, which this variable is the number of days between the date of diagnosis and then the date of receiving their first treatment. So for surgery, the longer the wait for treatment, the less likely patients adhere. So if they waited between 15 to 28 days, they were 77% less likely to adhere to surgery. If they waited more than 28 days, they were 85% less likely to adhere to surgery. And then for radiation and chemotherapy, the longer the wait, the more likely patients adhered. So those are just some of those findings. So in conclusion for Project 1, Appalachian colorectal cancer patients had greater odds for CRC treatment adherence than non-Appalachian patients. However, 1/3 of these patients are still not getting the recommended treatment. So we'll move on to Project 2. So with this finding from the last project, we decided to do a qualitative study to explore factors of why colorectal cancer survivors adhere or don't adhere to the recommended treatment. So this is currently in progress right now. And we are conducting qualitative interviews with CRC survivors residing in Appalachian counties, specifically in Tennessee. They are 60 to 90-minute telephone narrative interviews regarding their experience with cancer and then their adherence to the recommended treatment. So as I said earlier, they're narrative interviews, so the interview is structured to have the CRC survivor tell me their cancer story. I think a cancer story is really personal and it's such a life-changing experience. I thought a narrative interview setup would be the best way to record this kind of data. So I tell them to literally walk me through the steps of when they were diagnosed to where they are right now. And I won't interrupt as they tell me their story. And then if they leave anything else that I'm interested in, if they leave that out, if it wasn't covered, I may ask a few questions at the end. And then participants are compensated with a $25 electronic gift card, which is a good incentive to participate. So our study population includes colorectal cancer survivors, and this is defined as any person who has a personal history of CRC. And then the inclusion criteria for this project is threefold. They have to be English speaking, reside in a Tennessee Appalachian zip code, and then have a history of CRC diagnosis, which I mentioned above about the definition of a colorectal cancer survivor. So for recruitment, we are seeking a convenience sample of 20 CRC survivors, and we think that will reach saturation of data. And we're doing this through direct advertisement. So some of the strategies I've used are media outlets such as online social groups and pages, local medical centers and hospitals that provide cancer care, and then snowball sampling, where I asked a participant to pass on my information to any CRC survivor they know in Appalachia, Tennessee, who may be interested in participating. And then to follow the IRB protocol, interested CRC survivors will go through the eligibility screening, which is the inclusion criteria, and then we will go ahead and schedule an interview. So the current status of Project 2 is still in the recruitment phase. So far I've conducted 3 interviews, and I've kind of made a list of my recruitment strategies in this slide. So I've contacted the local American Cancer Society in Knoxville, and I've either talked to them about other contacts that they can connect me with, or I've given them my recruitment material so they're willing to share it. And I'm still using that outlet right now during recruitment. I've also shared my recruitment materials with the University of Tennessee Medical Center with their oncologist. I've shared it with local hospitals and clinics in the area that provide cancer care. And then I have shared recruitment materials electronically in social groups. So the Colon Cancer Alliance, advocates that Fight Colorectal Cancer, which is how I found Fight Colorectal Cancer's website and why I'm here today. And then Colorectal Cancer Survivors Unlimited. So I just kind of want to wrap this up with a few lessons learned so far. I honestly thought I wouldn't have trouble in recruitment, but Appalachian, Tennessee colorectal cancer survivors is what I would consider a hard to reach population. And that's either because I'm not using the correct outlets to find them or the correct techniques, or maybe my eligibility criteria is too narrow, but otherwise it's been challenging. Another big lessons I've learned is with the eligibility screening and interview scheduling. So I'm still fairly new in my doctorate. I'm in my second year, and this is my first time conducting interviews for my own project. So the only other experience I've had is with interviewing doctors and nurse practitioners. And this population is a little bit different since they're used to a specific protocol, and they love to schedule in Microsoft Outlook or Google Calendar, whatever they use, and they have secretaries. So they're kind of used to the back and forth communication with, like, are you eligible? I need to have a consent form signed and sent back to me, and then scheduling the interview. It's a process. However, with this population, with Appalachian CRC survivors, I've learned that the more back and forth communication I have with a participant, the easier I'll lose them. So I've learned that I need to be more concise and ready when I have them on the phone or through email. So go ahead and screen them the moment I hear from them, and then schedule the interview. I've also learned that reading the consent form over the phone and then proceeding with the interview ensures that I won't lose them. I still need to follow IRB protocols, so offering to mail them a consent form that they could sign and mail back to me instead of having them mess with scanning and emailing, because some of them aren't as comfortable with that. So basically making it as easy as possible for the participant to participate is the biggest takeaway I've learned so far in this project. And for future directions, it'd be to continue and develop new recruitment strategies. And I don't know if anyone has any other thoughts or ideas that they'd like to share. I'd love to hear it. One of the things that I thought was expanding my IRB to include all of Appalachia instead of just Tennessee. I thought maybe that may make more room to find more participants, but then we lose that the specifics related to Tennessee. And then also in the future, when I am scheduling interviews, to keep the back and forth communication to a minimum. And then in the long run, hopefully from this project, we'll be able to identify factors that influence treatment adherence in colorectal cancer survivors in Appalachia. And hopefully these factors that we identify can help future programming and tailored interventions to improve treatment adherence, and then overall reduce colorectal cancer mortality in this region. And that's my last slide. I think I went through that pretty fast, but I think we open the floor for questions or comments or anything like that. And I just want to thank you guys for the opportunity to share my research, and thank you to Fight Colorectal Cancer for helping me try to find participants for this study. They helped me out a lot looking through their connections, and I was able to get 3 of them from you guys, so that's great. And yes, I'll stop there.
Awesome. Well, thank you, Amanda. That was very informative. I enjoyed hearing about both your projects, and I think it would be awesome if down the road, once, you have findings from the second project, if you'd be willing to either share on those or even, do another learning lab, because I think this research says a lot about not only this specific community, but the whole CRC community at large, and treatment adherence. So with that being said, does anyone have any questions off the bat? Okay, well, I have a question for you. Do you have any idea, or do you know if any studies have explored why this specific community has a greater burden of colorectal cancer?
So, like I said before in the presentation, the literature is very limited in Appalachia, like almost non-existent. I only was able to find literally one article that looked at specifically colorectal cancer in Appalachia. So there really isn't a lot to go on there. Yeah, the only thing that even trying to find like the rates, like the specific rates of mortality in East Tennessee is hard to find too. So, like I said, the literature is just very limited. But looking at other cancers has helped kind of inform this research path.
And has your research looked at, like, for example, I know a lot of times communities that have transportation barriers have found that it's a lot harder for them to get in for a colonoscopy, or I guess in this case, get in for chemotherapy and treatment. Have you all looked at or thought about how maybe environmental factors like transportation could serve as a barrier to this population?
Right. So that's kind of what we're hoping to find out in the qualitative study, phase 2, to see if maybe the environmental factors could definitely be something that affects, why they aren't adhering to their treatment. But hopefully that's something that we'll find out from the participants.
Right.
I do see there's a question in the chat box. It says, I'm not sure I'm clear where they're looking for recruitment. Is it just Tennessee? So I'll just answer that. Right now, yes. My IRB is for Appalachian counties in just Tennessee. However, I've talked a little bit with my advisor, and we were thinking about maybe broadening the sample into all of Appalachia, since we're having trouble finding enough participants just from Appalachian counties in Tennessee.
Great. And does anyone else have any other additional questions? All right. Well, thank you so much again, Amanda, for joining us today. And like I said, we'd be very interested once, the second project gets going and you have your findings, we'd be interested in hearing how that turns out as well and what the broader implications are. So thank you for joining us, and I will be sure to send you all the link to this recording.
Okay, great. Thanks so much for the opportunity, and I'll be in touch with the second phase of this project.
Great. All right. Thank you all for joining. Have a good day.
Take care.
Bye.